Alon, you're keeping the group chat alive.
I'm sorry.
No, no, I love that.
I'm trying my best.
That is the energy we need. When I read that message last night, I was just I was like, yeah.
I'm like, I don't like tea, but like, it sounds like fun.
Suicide note. It's like this.
Hey, are those your scrubs?
Huh?
Are those your scrubs?
Yeah. When I get these.
No, gabapentin is.
Oh my! No, these are my.
So tell me how you want to do this. Do you want me to go over the important things? Do you have questions? Important things. What I may ask, okay, I can do that. I already wrote the question, so I can do that. So what I can tell you is that you have to be able to identify the main tissues in a histological section. That's what I can tell you. So regarding gingiva, okay, let's see if I. So what is the important thing regarding gingiva? First, is an example of an oral mucosa. So you need to remember basic things regarding oral mucosa, which means epithelium, stratified, squamous. Which cell layer is the one that proliferates in a stratified epithelium? The basal layer, the one attached to the basement membrane. Remember the structure of basement membranes because it's critical for establishing cell polarization, okay? And that structure is going to be very useful when you work on the junctional epithelium. So regarding the histology, and this thing doesn't work here. So regarding the histology of the gingiva, the most important things that you will need to learn are you need to be able to identify the outer gingival epithelium from the sulcular epithelium from the junctional epithelium. Okay, so that is very important. Regarding the things that you should know and remember, and I have to tell you that from my conversations with Professor Gay, there are a few things that I may ask in the final exam that requires that you remember from oral biology course. Okay? So, characteristics of dentin, characteristics of enamel, particularly dentin, because during periodontics, what happens when there is periodontal disease? Bone is lost, but also the root may be affected, right? So the root is affected. What is the first tissue of the root that is going to be affected? Cementum. And cementum is very thin. So what do you believe regarding sensitivity? Your patient, if you have a patient with exposed cementum, is it going to feel pain? Is it going to feel heat and cold? Yes. Why? Cementum is not innervated. And this is what you need to remember from dentin. Cementum is so thin that dentin sensitivity is what is going through the cementum. Okay, so those are things that you need to remember. Okay, regarding the oral mucosa, in general, you need to remember the organization of the tissue as it is, and also which cells are responsible for different functions in the epithelium, for example. So remember, the Langerhans are some cells that are going to be important for you when you are working on gingivitis. Because what is the role of the Langerhans cells? Anybody remembers? Antigen presenting cells. So periodontal disease always starts as a gingivitis. And gingivitis starts because infection or ingression of bacteria through the gingival epithelium. So which cells initiate the immune response during gingivitis? The Langerhans cells. And the Langerhans cells, what they do is they incorporate via phagocytosis the bacteria, break it into pieces, expose pieces on the surface. They leave the epithelium, go to the connective tissue and through lymphatics to the ganglia, where they connect with the T lymphocytes to initiate the response. Okay, so from now on, what you need to think are a lot of how to apply what you learn in the diseases and in the treatment. Okay? So for the oral mucosa, the Langerhans cells are the most important regarding possible treatment or and response to mediate the immune response. Okay? The other thing that is critical to remember as an oral mucosa in general is that as a seal to avoid losing water and also to be an effective barrier, the tight junctions are critical. Okay? The desmosomes, what do the desmosomes offer to the mucosa? Mechanical gingival epithelium, because the gingival epithelium, the outer gingival epithelium, is what type of mucosa? Lining, masticatory, or sensory? Masticatory, right. So if it is masticatory mucosa, mechanical strength resistance is critical, so desmosomes are critical for that. Okay? What cell junction mediates the attachment of the epithelium to the connective tissue underneath? Hemidesmosomes, very good. And those are mediated by integrins, and they are connected with the intermediate filaments in the cells. Okay? So those are some of the basic things regarding the epithelium. Another thing to remember is that the gingival epithelium, like any epithelium, turns over quite fast, and generally it takes 14 days to go from the basal layer to the superficial layer. Okay? It's even shorter than in the skin. Okay? So that capacity for turnover is very important. And remember that during this process of differentiation of the keratinocytes, the cells go from cuboidal, and when they are attached to the basement membrane, able to proliferate, they are in cycle. But as soon as they detach from the basement membrane, they come out of cycle. And they grow in size in the stratum granulosum, then they become flat in the stratum spinosum, they're bigger, then they become flat in the stratum granulosum. And then we have the stratum corneum. And that's true for the outer gingival epithelium because it's keratinized epithelium. The sulcular epithelium is involved in mastication? It's not. So, therefore, is not keratinized. Okay? Okay, so that Merkel cells are sensory cells, are mechanoreceptors present in the epithelium of the oral mucosa. And the melanocytes, you remember, those are the cells that produce melanin that protect from damage from UV light. Okay, so let me see. Lamina propria. The important thing here to remember is that the lamina propria consists of two regions, the papillary layer close to the epithelium, more cells than fibers, and below the reticular layer, more fibers than cell, and that's when you can see thicker collagen bundles of fibers. And the functions of this tissue is like in any connective tissue. It gives support, it brings or allows the transport of blood vessels, lymphatics, and nerves. Those are the main critical functions of the connective tissue. The other thing is that most of the fight of the host against gingivitis is going to happen in connective tissue. It's not going to happen in the epithelium. It's going to happen in the connective tissue. And that is through what we call, if you remember, the non-resident cells of the connective tissue. Macrophages, the granulocytes that come, the most common granulocyte that happens during the beginning of an immune response. Remember, there are three types: neutrophils, eosinophils, and basophils. The most common to find, because it's the most abundant, the neutrophils. Okay, so those, and then we have plasma cells, the final differentiation state of the B lymphocytes. All that happens in this area. Okay, that's the most important things to remember regarding the oral mucosa. If we go into the areas in which you see a submucosa, the submucosa obviously is under the mucosa, and that's where you may find the minor salivary glands. Okay, and you may have some adipose tissue. It's not going to be really involved in any clinical aspect, really. So I didn't ask any questions regarding submucosa. So it's important that you are able to identify your typical keratinized epithelium from non-keratinized epithelium. Okay, so that's the first thing. The keratinized epithelium is going to have the most superficial layer is going to be dark pink, and you're not going to be able to see any cells or any nuclei in it. So that's the clue or the key to be sure that that's keratinized epithelium. The absence of actual cells. You can't see cells, you can't see nuclei. You just see a dark pink layer on top of an area where you can see cells. Yes?
And again, the reason why the outer epithelium has that keratinized tissue is for the protection.
It's because it's a masticatory mucosa. So if you think about, in order to know which is masticatory mucosa, think what areas of the mouth are in contact with food when you are eating. The top of the tongue, the area in the teeth, the top of the palate, okay? The hard palate. All those require keratin because they require extra protection, okay? So that's why the outer gingival epithelium is keratinized. Now, compared to the non-keratinized, here, the first thing you see is that the most superficial layer is not darker than the others. Look up here. This is darker than this area here. But in this one, there is not a very dark area. And then you can see nuclei up to the end, and those nuclei are, let's say, how can I say this? They're not big, but they don't look completely dark, which means the chromatin is not completely silenced. In between these two, we have the parakeratinized, and it's one in which it's a combination of these two. From the keratinized epithelium, the most superficial layer is darker. And from the non-keratinized, you can still see some nuclei in there. That's what you should use to see that. So, in general, the epitheliums in the oral cavity are in two states. They are keratinized or they are non-keratinized. But over time, non-keratinized epithelium may become first parakeratinized. And if we are talking about a heavy smoker, non-keratinized epithelium may even become keratinized epithelium. Okay? So the natural states are non-keratinized and keratinized. The non-keratinized may respond to the constant damage by becoming first parakeratinized and then keratinized. Examples of that is because the sulcular epithelium of the gingiva is naturally non-keratinized epithelium. But because over time and with age, it becomes sometimes more exposed and bacteria go in, it's turned into parakeratinized epithelium. Okay? So from a histological point of view, this is the main thing that you need to be able to identify. Then obviously you need to be able to identify the three types of epitheliums in the gingiva. When you look at histological section of a tooth, the first thing you need to think is this: the enamel is gone. That's the first thing to know. So this area here, part of the tooth, is denting. Okay? So the epithelium that is exposed to the environment, this side, if this is the tooth, this is the epithelium exposed. So this is the outer gingival epithelium, is keratinized. And if you look at the end, you see that ondulation. Those are the retepegs of the epithelium. And those retepegs are present only in the outer gingival epithelium. That's the main thing that you can use to distinguish between the three types of gingival epithelium. The second is the sulcular epithelium, sometimes also known as inner gingival epithelium. And this is non-keratinized, but sometimes, and generally close to the top, it can be parakeratinized. Okay? And this epithelium, obviously, you need to know the function. What is the main function of the sulcular epithelium? It helps or allows the passage of the crevicular fluid. It's not involved in the most of the production of it. The crevicular fluid is what? Exudate from the blood vessels of the lamina propria. Okay? So the sulcular epithelium may add a few things produced by the cells, but most of the crevicular fluid is an exudate from the blood. The sulcular epithelium here has to be able to allow the permeability, the crevicular fluid to go through. That's why it can't be keratinized. If it was keratinized, it's not going to allow the passage of the crevicular fluid. Then, how to identify the junctional epithelium? The easy way is always look at the length of the whole thing. Around the middle is where the enamel should start. Therefore, this inner middle is the junctional epithelium. That's the easy way for you to identify it. Okay? Structurally, yes, there is differences. The cells of the junctional epithelium, they're in general, all of them are flat, in general. And we have a few layers, and the number of layers may change. The junctional epithelium is the critical one for you to remember. And remember what we talk about. Let me come back to this. I have a couple of questions of junctional epithelium, okay? And that's because if you remember when we were talking, I told you I added a new concept for this lecture that I didn't tell you during oral biology. And that was the transformation of the junctional epithelium into the long junctional epithelium. And that is result of pathology. So you need to know all the characteristics of the junctional epithelium. As I say here, generally it starts towards half of the space that you can see in a section. So the sulcus is the small area in white. The sulcus should be this small area in white. That's the normal sulcus. This big space is the result of losing the enamel. And the junctional epithelium, if you look at the whole length, is generally around half of the whole length. Okay? The junctional epithelium, you need to remember unique characteristics. It's the only epithelium in the body who doesn't have a free surface. It has the basal side connected to the lamina propria, and the apical side bind to the enamel and a little bit of cementum, but mostly enamel. Okay? You need to remember that there are two types of lamina or in basement membranes involved in this epithelium. The one that connects with connective tissue is similar to any other basement membrane that connects an epithelium to connective tissue. So remember the structure: lamina lucida, lamina densa, and lamina reticularis. A marker for that, collagen type 4. Okay? In the case of the junctional epithelium, the apical surface also makes a modified basement membrane, which is the internal basal lamina. It has something similar to hemidesmosomes, but the difference here is collagen 4 is not there. So the internal basal lamina that connects the junctional epithelium to the enamel and a little bit of cementum does not have collagen involved. Okay? And if something fails in that connection, remember, the result is bacteria can go through, and because it's deep into the sulcus, what is going to happen? It's going to go straight into the PDL. Yes?
So you said the internal one has no collagen involved?
No collagens involved at all.
What about the external?
The external is your normal basement membrane. It has collagen type 4, laminins connected with collagen type 7, and then the collagen 1 in the lamina propria. Think about this. The junctional epithelium, when it's connected to enamel, is not connected to connective tissue. So no collagen. It's the easy way to remember that. Okay? Okay. So the new aspect of the junctional epithelium that I told you is reinforce the development of the junctional epithelium, which I think is, I have it, where did I put it? Here, the development of the junctional epithelium, okay? So the embryonic origin of the junctional epithelium is the reduced enamel epithelium. So originally, the primary junctional epithelium are the ameloblasts that stop producing enamel. So if you remember from tooth development, before eruption, on top of the crown, on top of the enamel, was a very thin cuboidal, simple cuboidal epithelium surrounding the enamel. That is the reduced enamel epithelium. Okay? And that is what becomes the primary junctional epithelium. Once the tooth erupt, obviously the most superficial cells died, but some leftover is going to remain. Okay? And that leftover is what become the primary junctional epithelium. Over time, the primary junctional epithelium is replaced by the secondary junctional epithelium. The origin of these cells, the gingival epithelium. Okay? With that comes the capacity for high cellular turnover with that. Okay? So, this brings me with a new part, and is this picture here. When you have periodontal disease, one of the first changes that you are going to see is this. Every black dot here represents cell proliferation. I'm running out of battery on this, okay? But one of the first things that happened when gingivitis is established and periodontal disease is gonna start is the overproliferation of the junctional epithelium. And it's that proliferation of the junctional epithelium that is happening at the same time that the connective tissue is being destroyed by the bacteria causing the infection. That combination of connective tissue being destroyed and the capacity of high proliferation of the junctional epithelial cells, what makes the long junctional epithelium. Yes?
So I thought with periodontal disease, like you also have like gum recession too, right?
Yeah, because what is going here is that the sulcular is coming lower, and then the gingiva in general start going shorter. But why do we call long junctional epithelium? Because at the very beginning, the junctional epithelium is barely attached to cementum, but at the end, there is a long distance of cementum, a long area of cementum that is attached to the junctional epithelium, a modified junctional epithelium, not a healthy one. Okay, so that's why we call it long junctional epithelium, and it comes together with a gum recession. Okay? So you have to be able to describe or define what long junctional epithelium is. Okay, you need to know that it appears or it happens once gingivitis is established and is the result of this fast production of cells from the gingival epithelium, from the junctional epithelium itself. Okay. So remember that I talk about it's a race. Once periodontal disease is established, and remember we talk about periodontal disease once bone is affected. Once periodontal disease is established, the body responds trying to eliminate the cause of the infection. And one of the things that our body normally do is if we have an injury that expose the inside of our tissues, the internal tissues, to the external environment, the first things that our body try to do is to close the opening, right? That's why we have first clotting, in order to close the opening to avoid more bacteria coming in. So in the case of periodontal disease, the body is doing the same thing. It's trying to close that opening. And there are two types of tissues that need to be formed there, connective tissue and epithelium. But from those two, epithelium is more effective by proliferation and is more effective by migration. So the epithelium wins the race between the connective tissue trying to recover and the actual junctional epithelium proliferating, trying to seal and block the passage in this area there. So that's why we have the long junctional epithelium. Okay? It's as a result of this race in which the gingival epithelial cells are better. Okay? Over time, once the infection is destroyed, if you don't do anything else, slowly and over months, the long junctional epithelium is going to become shorter and shorter and shorter. But you, as a dentist, what you are going to try to do is this guided tissue regeneration. That's part of one of the most used periodontal treatments once you have severe periodontal disease. So the guided tissue regeneration uses the knowledge now from the tissues to say, well, if I really want to recover the connective tissue, I need to stop the epithelium from doing what it normally does. So in this type of treatment, generally a barrier is inserted in the space, which is going to block the epithelium. It's gonna be a barrier, so it's not going to allow bacteria to go through, but it's going to block the epithelial cells, so it gives time to the connective tissue to grow and reestablish itself. Okay? Because what do we prefer? Do we prefer to have a long junctional epithelium, or we want to have a normal periodontal ligament? We want a normal periodontal ligament because the periodontal ligament is the one who has the collagen fibers that attach the tooth to the bone. Obviously, we need to make the bone grow at the same time. Otherwise, if we may repair the PDL, but if we don't have bone to attach the collagen fibers, it's not going to happen. So you are going to work with membranes that not only block the epithelium, but if you want to make bone grow, what growth factor you use? BMP, bone morphogenetic protein. So that's one of the growth factors that you're going to do. Okay, so identify the three types of gingival epithelium and histological sections, know what they do, remember the composition and formation of the crevicular fluid, remember the history of how the junctional epithelium is made, why we have the formation of a long junctional epithelium, and how, as a dentist, you can prevent that. During all this time, also, remember that before the epithelium is able to grow, cementum is exposed. And the patient may have sensitivity to cold, heat, and also some pain. And for that, you need to remember the possible mechanisms by which dentin is sensitive. Do you remember some of them? One possibility is that nerve terminals go through the dentinal tubules all the way to the end, so they are able to feel or sense changes in temperature or pressure. The other is the movement of fluid through the dentinal tubules, which are going to affect the actual odontoblast, which then connect with an axon from a nerve, or the fluid movement will affect directly the axon. Okay? Those are the most important ones for you to remember. Okay, so definitely there is going to be something like this for you to identify one of the main groups of fibers involved in the gingiva and also in the periodontal ligament. And in each case, you need to know from what structures they connect. Okay? So the dentogingival group, that's easy. Dentogingival is going to go from cementum to the gingiva, and it's going to go, look at the connection, it goes towards the outer gingival epithelium. What do you think is the function of those fibers? Those fibers are the ones that doesn't allow the gingiva to move to the outside. It keeps them in position. Okay? Then you have the alveolar gingival fibers. They go from the alveolar crest all the way to the tip of the gingiva, connecting outer epithelium and sulcular epithelium. Okay? Then the dentoperiosteal go from cementum all the way to the outer side of the bone, because the inner side is going to be used by periodontal fibers. Okay? And then the circular fibers that surround the tooth. The other group that is critical, transeptal. Unique because two things to remember transeptal fibers. Location, where do you find them? Exactly at the tip of the alveolar crest. That's where the transeptals are. Second important thing, connect cementum to cementum. Is the only example in which two teeth are connected. Okay? Okay. So, in a histological section like this, you need to be able to tell me, where did I left that there? Oops, I moved it, sorry. outer gingival epithelium. Dentin, cementum. This group of fibers go from cementum to outer gingival epithelium. So it can only be the dental gingival group. If we follow this here, it's not so easy. This is a periodontal group of fibers, right? But if we follow some, we can see some coming to this side. But it's very difficult. I didn't use a picture like this. But you have to be able to identify those fibers and those tissues, okay?
But that one right there that you just pointed to, you call that?
This is dentogingival, okay? Okay, let's see what else from here. Okay, I'm not asking anything of this, okay? But a picture like this area here, what tissue is this up here? Cementum. This is a typical example of a picture used to ask why the patient has sensitivity, in this area of the tooth, or when this area is exposed and not this one. That's because the cementum is very thin, particularly in the close to the cemento enamel junction. Therefore, the dentin below is the tissue that really is giving the sensitivity to the patient, not the cementum itself. Okay? So mostly that's it. Regarding cementum, remember the types of cementum. We have two big subtypes, acellular and cellular. Which one is the most involved in the attachment of the tooth to the bone? Cellular or acellular? Acellular. Okay, that's probably is the most important thing for you to remember regarding cementum. Okay, remember the cementum is going to grow by apposition. That's how you are able to see these lines. These lines here represent the increment lines of Salter, which are the growth lines for cementum. Okay? And if they grow by apposition, cementoblasts are going to be located on the surface. Oops. Here, on the surface here. Okay. Okay. So you have to be able to identify and distinguish between acellular cementum and cellular cementum. Which of these two types have the or show the more plasticity as a tissue? The acellular or the cellular? The cellular. So that means that the cellular is the one that is going to be better to respond to any type of change in the radicular area of the tooth. Cementum grows during lifetime or not? Yes, it does. Where is going to grow more? On the cervical half, where we have acellular cementum, or the apical half, where we have the cellular cementum? In the apical side, where we have the cellular cementum. Okay, and that knowledge is used sometimes in forensics to help determine the age of the owner of the teeth. Okay, so how do we call the portion of the collagen fibers immersed in cementum and immersed in bone? Sharpei fibers. Okay, so that's a name that you need to remember. Okay, regarding composition, regarding the composition of the matrix of cementum. cementum is the least, the most, or average regarding mineralization of the tooth tissues or the tissues in the oral cavity. Is the least mineralized. The most is enamel. Dentin and bone are quite similar. The least is cementum. But cementum is the one who has one particular chemical element in high concentrations compared to the other, and that's fluoride. So the higher amount of fluoride is going to be found in cementum. Okay? Then, here, because the tissue is mineralized, when the tissue is mineralized, can diffusion of nutrients and oxygen can happen when you have mineralized tissue? It can't. So that's why, for example, in bone, we have the osteocyte extending those filopodia in every direction, connecting to other osteocytes until we reach the center of the bone. You remember the osteon unit? The center is where we have the blood vessels, and that diffuse from the blood vessels to the first line of osteocytes that share that with the next ones and the next ones and the next ones. So in the case of cementum, it's mineralized, so it needs to have blood vessels close by. But the cementum itself is vascularized or non-vascularized? It's non-vascularized. So that is telling you two things. First, it has to be close to connective tissue. Second, it has to be very close to connective tissue, because which is the connective tissue close to the cementum? The PDL. So the nutrients are going to come from the PDL. So the cementocyte is going to extend the filopodia towards the PDL. And in general, we don't see more than of these cementocytes are not alive when they are deeper than 50 or 70 micrometers from the PDL. In images like this, let me come back here, like this ones here, this cementocyte and probably these ones, they're dying, okay? Because they don't receive enough nutrients from the ones close to the surface. And they are absolutely dependent from other cementocytes close to the PDL to survive. Okay. So during periodontal disease, not only you're going to lose bone, but cementum is going to be affected also. So you need to reconstruct cementum. Fortunately, cementum is not easily degraded as the bone. So the reconstruction will mean mostly for the fibroblast of the PDL that are recovering to produce what type of fibers in the cementum that are responsible for the attachment. We have intrinsic fibers and extrinsic fibers. Which type of fiber is critical for attachment? Extrinsic, and we call them extrinsic because they are made by fibroblasts from the PDL, from outside of the cementum. The intrinsic ones are the ones made by the cementoblast, but they are not involved in the attachment. Okay? So this is your typical cementocyte, and the canalicula and the filipodia go only in one direction. This is what is telling you that this is cementum and not bone. Because if it was bone, here, the filopodia will go in all directions surrounding the cell. Okay? So if we go deep into the classification of cementum, you need to remember that we have close to the neck between the crown and the root. Oops, this is very easy to move here. Acellular, afibrillar cementum. So there is no collagen fibers in that cementum matrix at all. Okay? It's only made by cementoblast, but there is no fibers and no cells. Very, very small in length, considering the whole length of the root, just very little. It's like a ring in the cervical region of the tooth, and it's very, very thin, between 1 and 15 microns, practically the size of a medium-sized epithelial cell, very thin. The second type is the acellular extrinsic fiber cementum, and this is the most important for the anchoring. No cells, but plenty of collagen fibers made by fibroblasts in the PDL. That's the critical one. Then we have a mix of cellular, who has extrinsic and intrinsic fibers. That's towards the lower half or the apical half of the root. And finally, we have an example of cellular intrinsic fiber cementum, in which we don't have collagen fibers at all. Collagen fibers made by the fibroblast. We have some collagen fibers, but they are made only by the cementoblast. This type of cementum, you need to remember, is the one that works during orthodontic treatment. So you did already Ortho 1, right, in the summer. So this cementum is the one that fill up the resorption that happens during orthodontic tooth movement. So regarding the permeability of the cementum, like with any type of mineralized tissue, diminish with age. So it becomes less and less permeable during age. And the permeability is what allows the cementum, the cellular cementum, to survive. But when it's very deep and very close to the dentin, the cells really died and we only have the space occupied for those cells. So this you need to remember, the types of cemento enamel junctions. We have 3 types. We can find the 3 types in any tooth in any moment. And the most common is the one in which the cementum overlaps the enamel. What is the main goal here? To protect dentin, because it's the sensitive tissue, right? So we have the most common cemento enamel junction is one in which dentin is protected by enamel, and on top of that, protected by cementum. It's double protection for dentin. And that corresponds to around 60% of the periphery of the tooth. The second type is this one, in which the cementum ends when the enamel begins. And that corresponds to 30% of the periphery of the tooth. And then finally, unfortunately, only 10% of the periphery of the tooth is in which dentin is a little exposed. Okay? So definitely this change a little bit, those percentages change a little bit with the type of tooth, but these are the average ones that are important and for you to remember. And also, in old books, the people used to believe that in one tooth, each of these was the unique way in which the connection, that cemento enamel was done. So when people believe that instead of saying 60% of the periphery of the tooth, people were saying 60% of the teeth have this type of connection. So now we know that's not the case. Those three types can be seen around forming that ring surrounding each tooth. Okay. So from this aspect here, just remember that in the apical foramen of the root, protecting the dentin is going to be cementum. And that cementum turn around and form the very entrance of the foramen. So the very entrance of the foramen is protected by cementum. Okay? That gives enough space to get to the pulp in the root. Okay? Okay, so regarding the thickness, because cementum grows continuously, the thickness is going to increase with age. Okay. The other thing is that in general, in the apical end, because this is where we find the cellular cementum, generally this area, the cementum shows bigger thickness, is thicker in the apical third than in the cervical third. Okay, so you have to be able to say in which area of the root you expect to find acellular versus cellular cementum. Okay. I'm not asking any of this. This is, you are already, yes, you are already have oral pathology, right? So this is in that, for that class. So I'm not asking, I didn't ask any of this. Regarding resorption, one big difference regarding the physiology of bone and cementum is that bone remodeling is happening continuously. It's part of the normal physiology of the tissue. In cementum, cementum remodeling and cementum resorption as part of that process happens only as an response to a stimuli, generally a deleterious stimuli. Okay, so normally the cementum is not remodeled. That's not part of the normal physiology. Only happens as a response to a stimuli. Okay, and in bone, the cells in charge of degradation, osteoclast. In cementum, cementoclast. Okay? And because this happens only when needed, it's very difficult to see them in any histological section. So no one is ever going to ask you to identify them. Just remember that the same way that the cementoclast are modified macrophages, the cementoclast are also modified macrophages. And during the process of cementum resorption, that resorption may continue and go over the dentin. Okay? And this is why then we need to repair this cementum. And the cementum repair is gonna come mostly coming from two possible ways. If this area was cellular cementum, the cells next close by, particularly the cementoblast up here, are going to grow into this area and repopulate the cementum. If this area was acellular cementum, we have, how is it called? It's not stem cells directly, it's precursors for cementoblast are located in the PDL. Those cells are going to establish themselves on the border and start depositing new cementum there and create new cementum by apposition. Okay, prepare. So as I said before, the cementoblasts are the ones that are going to repair cementum. And apparently, the epithelial cells of malassez may be involved also. And that is because it is, if you remember from last semester, no, the spring semester, that it is believed that some stem cells reside in those epithelial rest of malassez. And people are showing some evidence that in some cases, the epithelial rest of malassez, those group of epithelial cells found close to the cementum, that when cementum needs to be repaired, those groups seems to disappear and some cells may be the ones responsible for cementum. But the main general answer is cementoblasts are the ones that make new cementum. Okay? Yeah. So regarding cementum, that's it. So, okay, let's go to bone to continue with mineralized tissues. So from bone, you need to remember the characteristics of the matrix, because the matrix is what gives the bone its characteristics. So around 70% of the bone in weight is mineralized, is mineral or mineral matrix. And the most abundant component is the hydroxyapatite crystals, which mostly depend on calcium and phosphate. Okay? We may found a few other elements involved, like sodium, magnesium, manganesium, but the most abundant is calcium. That's why we say that bone is the storage for calcium in the body. Okay? So the organic components represent around 30%. I think I forgot to click the shift, so that's why it looks like 3 or 5, but it's 30% is organic matrix. The name of the organic matrix is osteoid, and the most abundant component of that is collagen type 1. 90% of that matrix is collagen type 1. Okay. The other thing that is very critical here are other proteins. From all of this, bone morphogenetic protein, this is the growth factor that controls the growth or deposition of bone. The other one that is critical is this, osteocalcin. Let's say that you have, and I'm going to dig into your memories from even pharmacology. You have an 65-year-old patient that comes to you and he has periodontal disease. And because of that, you know bone is involved. So you need to find a way to improve the deposition of bone in that patient. And the patient, obviously, you need to take a medical history, right? The medical history tells you that this patient has been diagnosed with a higher risk to develop blood clots. One of the most common medicines or drugs to treat that is warfarin. Warfarin functions by blocking vitamin K. Vitamin K is necessary for the production of the coagulant factors in blood. That's why it was prescribed warfarin. Now, the second most abundant protein in the bone is osteocalcin. And osteocalcin is the one that regulates the mineralization. And osteocalcin needs vitamin D. That's why, for those of you who have children, you were told, oh, it's a baby. You need to expose to sun 10 minutes a day. It needs to have some vitamin D. One of the reasons is because osteocalcin requires vitamin D to function and is critical for the mineralization of bone. Osteocalcin also uses vitamin D, the activity of vitamin K. So a patient who has been in warfarin for a long period of time is going to present you with two problems. Has been in anticoagulants. You touch and damage tissue, is gonna bleed for a long period of time. You can fix that, but asking the doctor of that patient, can this patient stop taking the drug for a week before I do the treatment? That solves you the problem of bleeding. It doesn't solve the problem of weak bones. And it doesn't solve the problem of trying to create more bone for you to recover that patient regarding the periodontal disease. So in cases like that, you need to work in coordination with the physician and find a way to reinforce that capacity for mineralize the bone, obviously without taking the medication, maybe reducing warfarin and giving extra medications for calcium deposition that is going to help to mineralization. Okay, so I'm sure all your clinical faculty told you, but your second year is where you need to start putting together what you learn in anatomy, in histology, in pharmacology, and you need to start putting it together to treat an individual. Okay, so warfarin is very important for you to remember, first because it's a common medication, second because affects bone. Okay, and you're going to be working with bone most time. Okay, so you need to be able to identify bone in a histological section like this, and you have to be able to tell me what cell is this, and you know, surrounded by matrix, osteocyte, cells on the internal periphery of bone or a trabecula of bone, two possibilities, osteoblast or part of the endosteum, which then there might be some fibroblast involved there. Okay, but in this case, for example, these cells are cuboidal, for sure, osteoblast. These cells here that seems to be a little more flat, those can be or inactive osteoblast or fibroblast of the endosteum. Okay. Remember the connective tissue of the periphery of bone. So the connective tissue surrounding the mandible is called periosteum. And the inner layer has osteogenic capacity. It can create and add bone by apposition. The other type of cell that you need to be able to identify is this, the osteoclast. Huge cells, multinucleated, they can have up to 20 nuclei, and they are always located on the surface, internal surface of the bone and trabecula. And that's what we call the house-shaped lacunae. Okay, so that is the histology that I'm going to ask you to remember for this or the final exam. Although I have to tell you, in the final exam, I'm going to have 5 questions for my lectures, and they are all going to be applied questions. So the examples I told you about the warfarin modeling, that type of question, the sensitivity of dentin or cementum, why? So those are the kind of questions that you're going to have for me. Okay? It's just 4 questions or 5 questions from the whole final exam, but you are going to have a few of them. So remember that the unit of bone is the osteon, but is the unit of compact bone only. Okay? And in the mandible, in the maxilla, we have compact bone on the periphery, and inside we have trabecular bone, or the other form is, it's the other definition of trabecular bone or spongy bone, spongy bone. Okay. Okay, so from this here, you have to remember then this area here corresponds to the body of the mandible, right? And in the body of the mandible, we have on the periphery compact bone, and then inside trabecular bone. The alveolar bone proper is the area of bone that forms the actual socket in which the tooth is located. Okay? And the actual alveolar or the alveolar bone proper also has compact bone on the periphery, and in some cases, we may have or not trabecular bone. It depends on how thick is the actual bone. Okay? But there is always an area of compact bone. Then remember then, in the periphery, we have periosteum, and in the internal surfaces, including the internal surface of the compact bone and all the surface of the trabecula, we have endosteum. And the endosteum has the capacity to be osteogenic. Cells of the endosteum can become osteoblast and create more bone. Okay? The same way that the inner layer of the periosteum is also osteogenic, because we may find in that inner layer of the periosteum osteoblast or progenitor cells to add bone from the surface from a position. Okay? So here you have the periosteum, is all this area here. The inner layer is the one that where you may find osteoblast, like probably this one here. Then all of this is compact bone. Why I know compact bone? Because of this. Haversian canal from an osteon, Haversian canal from another osteon. And osteons are only present in compact bone. Okay? This is the inside. Why can you say that this is the inside of the bone? What type of tissue is this? Adipose tissue. Adipose tissue is part of the bone marrow, therefore is part of the inside of the bone. So this bone here is an example of trabecular bone. And these cells here are part of the endosteum, and some of these can be osteoblasts. Okay. Okay. Regarding bone remodeling, remember that it's made in 4 phases. One phase is the initiation, is the phase in which the signals that tell the cell you need to recruit osteoclast and activate them. The second phase is the actual bone resorption. The third phase is another phase in which the signal says stop degrading bone. The fourth phase, bone deposition. Okay? Those are the classic phases for bone remodeling. Osteoblasts are the cells that are actively producing bone. Osteoclasts are the ones that are actively degrading bone. But osteoblasts are critical to create osteoclasts and to activate osteoclasts. And again, I'm going to dig into your memories. In order to create an osteoclast progenitor requires 2 signals: macrophage colony stimulating factor, made by osteoblasts, and requires rank L, made by osteoclast, but attached to the membrane of the osteoblast. So to produce an osteoclast, there has to be a very close interaction between the primordial osteoclast and an osteoblast to allow the connection between rank in the primordial cell and rank L in the osteoblast. Once several primordial osteoclasts are formed, they fuse. And that's why osteoclasts are multinucleated and big cells. The next step is the activation, and that's when osteoblasts are needed again. And they are needed because they produced and released rank L. In this case, the rank L is not attached to the membrane, it's released into the external environment. And when that happens, the osteoclast is activated. And if you remember, the first things that need to happen to degrade mineralized tissue, being bone or cementum, the first thing that we need to do is to eliminate the mineral. If the mineral is not eliminated, the proteases can't reach the proteins in the matrix. So how do we demineralize tissue? By submerging bones in acid. So the osteoclast, what it does is create a very small cavity under it between him and the bone and releases protons into that cavity. That acidifies the environment. That acidification releases the mineral from the matrix, and then the osteoclast, by exocytosis, releases proteases, proteases that require an acidic environment. So everything works together. Then the organic matrix is degraded. Everything is captured back by the osteoclast. That's how we reuse the calcium from the bone to the rest of the body. The osteoclast captures calcium back, captures peptides back, continue to process those peptides until it's able to release amino acids from the opposite membrane and releases calcium, which is captured by the blood and then sent to the other parts of the body. Okay? The important thing here is osteoblast, bone deposition, osteoclast, bone degradation. First, we need to eliminate the mineral, then the proteases produced by the osteoclast can degrade the organic matrix. Okay? The osteoblasts also are the ones that stop the osteoclast to function. So they initiate or activate them by releasing rank L. But then, after a certain time, by sensed by the osteocytes that send signals to the osteoblast and said, we need to stop degrading bone. What does the osteoblast do? It produces osteoprotegerine. And osteoprotegerine binds to rank L, and when rank L is not available to continue activating the osteoclast stop working. So even though we have osteoblasts producing the matrix, the osteoclast degrading, the osteocytes being the sensors, the osteoblasts are involved in all the stages of the process. Okay? So they are the fix-it kind of cells in bone remodeling. They do everything. So this part here is important for you and is going to be more important when you go over Perio 2 and go more into application. You need to remember the basic factors that can stimulate bone formation or bone degradation or block each of them. So any factor that regulates the activity of the osteoblast is going to regulate the formation of bone. BMP is one of the growth factors that you need to remember, and it's the easy one because of the name, bone morphogenetic protein. TGF-beta, if you remember, TGF-beta main function is to regulate the production of extracellular matrix, and that's important for bone formation. Okay? So those are growth factors, the two more important growth factors involved in regulating osteoblast production of bone matrix. Then we have the parathyroid hormone produced by the parathyroid gland that hormone, this hormone, stimulates bone resorption. Okay? So everything that is in green promotes bone deposition. Everything that appears in red promotes bone degradation. So parathyroid hormone is one of the main hormones involved in promoting bone degradation. Okay? Then, and all of these act on the osteoblast. Factors and hormones that act directly on the osteoclast, obviously we have rank L that activates the osteoclast for degradation. Estrogen. Estrogen inhibits bone degradation. So that's why when females go over menopause, we tend to have higher levels of osteoporosis than a man on our own age, because our bodies are used to have a high volume of estrogen that blocks osteoclast. When this estrogen is gone, then a big element in the blocking process of osteoclast is gone, and that's why we have osteoporosis in bones. And then what else? Osteoprotegerine and calcitonin, these two block the activity of osteoclast. So these are important because in some cases, you need to know the medical history of the patient to see if it's female and is in menopause age, or some females can be younger and they went over surgical menopause. So it's important that you know the medical history of the patient, and then know if you can use some of this to produce bone. That's, for example, if you want to regenerate the PDL, and for that you are going to need to regenerate bone, you are going to use a membrane rich in collagen, which is going to help the migration of fibroblasts to recreate the actual PDL, but also BMP because it's going to help the production of bone. You may also add to that membrane TGF-beta to help the production of collagen by the fibroblast and the matrix for bone by the osteoblast. So you are going to understand why of the treatments that you are going to use include some of these, mostly those that create new bone. Okay. Okay. So the alveolar process. The alveolar process then is the actual socket in which the root of the or roots of the tooth are located. And it consists of a cortical area, cortical bone area, that sometimes is also known as lamina dura or lamina dura, that you can see in an X-ray, as I imagine you are already learning with Professor Dixon, right? So this white line here that runs parallel to the root, that's the lamina dura, an example of cortical bone in the alveolar process. Then towards, in this case, if this is the lamina dura, this area here is occupied by trabecular bone. And we have on the other side another region of cortical bone forming the lamina dura on towards the root of the next tooth. Right? So that long wall that forms the socket is what we call alveolar process. Then when we talk about alveolar bone proper, it's just half of it. Is the cortical bone associated with the root in particular. That's what we talk about the alveolar bone proper, because it's associated with one tooth and not with two. Okay? And then within the alveolar bone proper is where we need to talk about the bundle bone. And a small section of that cortical bone is known as alveolar bone. And is known as alveolar bone because it's the area in the bone in which you can see the Sharpei fibers inserted. So from this area, let me go back here. Oops, wrong direction. Okay. I'm too short in here, but oops. Okay, so no, this is not very good. Sorry. These are not very good images for what I want to say. Okay. Well, let's use this one. So all this area here is cortical bone, right? The very surface, the first third, that is the area where the bundle bone is located. So just to be sure, bundle bone is the closest area of cortical bone next to the PDL and is the area in which the Sharpei fibers are inserted. Do we have bundle bone in other bones? Yes, because it's the same where ligaments attach to bone in other parts of the body. Okay, so every time in which ligaments attach to bone, the area in which the collagen fibers of the ligament insert themselves in the matrix of the bone, that is known as bundle bone. Okay, so it's not unique for the alveolar process. It's common for all the bones that are in contact with a ligament. Okay? Okay. So, considering this, the interdental septum is the portion of the alveolar process which is shared by two teeth, right? In between teeth or in between roots. Particularly, we use it for, it's very well known, it's used as an interdental septum for the on monorooted teeth. And it's this thin area here that is the interdental septum. And this is what is important to remember for you. If the interdental septum is very narrow, it only has the cribriform plate. That means the cortical bone with the holes, the foramina that allows the passage of blood vessels from the bone to the PDL. Okay? If the interdental septum is wider, that's when you can also see trabecular bone in between two cribriform plates. Okay? That is a concept that is important to remember when you are analyzing the x-rays. So if the interdental septum is narrow or thin, it's only the cribriform plate. If it is wider, then we also have trabecular bone. And this brings me to these two things, fenestration and the other one, dehiscence. Fenestration means it comes from French, fenestre, which is window. And you have to be able to describe this as a fenestration and this as an example of dehiscence. And the main difference here is that in the fenestration, in reality is a window, completely the borders are made of bone, whole borders made of bone in the fenestration. In the dehiscence, the superior border, there is no border of bone at all. So that's the main difference, okay? So you have to be able to discriminate between those two possible pathological examples that you see in bone. And it's quite common. 20% of the teeth are going to show one of these two forms. Okay? And the last one is the PDL. What is important here for the PDL? You have to remember the average width. The average width of the PDL is between 0.15 and 0.38 millimeters. Okay? You need to know that it changes with age. The older we are, the thinner the PDL becomes. But the PDL is very plastic, and it also can respond to being overused or being not used enough. That means someone who is chewing gum constantly for years and years and years, the chances are the width of, in average width of its PDL or his or her PDL are going to be closer to 0.38 or more. A person who is into juicing and is not chewing, or a person who requires to be on, it has a tube, a feeding tube, for example. These people are not making mechanical forces into their teeth constantly because they are not chewing. Therefore, the width of the PDL is going to become thin. So remember the average width. Remember that with age become thinner, but also remember that it responds to overuse or not use at all. Okay? And we have physical functions. They transmit occlusal forces and resist mechanical stress. Formative and remodeling capacity, because they are able to form more bone or form more cementum and remake themselves. And also has nutritional and sensory functions. Nutritional, because it's connective tissue full of blood vessels and is surrounded by cementum, which is avascular, so offers nutrition to cementum, and it also helps to the most superficial bone. And sensory, because there are two main nerve terminals in the PDL that comes from cranial nerve number 5, the trigeminal nerve, and the branches from the trigeminal nerve are going to get into the PDL, and the two more abundant are naked axon terminals, mostly pain receptors, and the second type, concentrated in the apical end, Ruffini-like, which are mechanoreceptors. Okay, so think about this. Pain is always going to be one of the most abundant receptors, always, in all tissues. And then in the PDL, the main function is resist mechanical stress. So it's expected that one of the most abundant sensory receptors in the PDL are mechanoreceptors. The PDL needs to know if it is under mechanical stress or not. Okay? So those are things that you need to remember from the PDL. Then you need to be able to identify the PDL in an X-ray like this or in a picture like this. Okay? In a picture like this, you also should be able to tell me what group of fibers will be present here. The transseptal fibers. Okay? Good. Composition. The main cell type in the PDL is the fibroblast. That's the most important one. But we also have another type of resident cell here, the epithelial rest of Malassez, left over from development of the root. Remember the Hertwig epithelium? The epithelial rest of Malassez are left over from development. And now we know that they may have stem cells that help the cementum. Okay? The others, resident cells, are those that we have in lymphatics, forming the lymphatic vessels and forming the blood vessels and the nerves. The other cells are non-resident cells, and they are all from the immune system. Macrophages, neutrophils, plasma cells, T lymphocytes, particularly T lymphocytes. Okay. Then regarding the fibers, we have the principal fibers, and those are the most important for you to remember. Okay? The principal fibers are made of collagen type 1 and collagen type 3. It's a mix of both, but it's around 80% collagen 1 and 20% collagen type 3. And then surrounding those, we have collagen 12. But the composition of the principal fibers are collagen type 1 and collagen type 3. These fibers are organized in groups. That's another thing that you need to be able to identify in a diagram like this one. You need to be able to name each of these fiber groups. You need to be able to identify them in a schematic diagram like this, and you need to be able to tell what are they responsible for. So, for example, if we go one by one, the first group is the alveolar crest group, and they are responsible to prevent the extrusion of the tooth, particularly when the occlusal tooth is absent. Okay? They also help to resist lateral tooth movement. So you need to be able to name them, identify them properly according to location, and be able to tell the function that each group do. The critical one for attachment of the tooth to the bone. Of all these groups here, alveolar crest, horizontal, oblique, and apical. Which is the critical one for attachment? The oblique. Okay? And because of that, is the most abundant group of fibers. And if I tell you what type of cementum is associated with the oblique fibers, is acellular. Even though in this diagram it seems to be pushing towards the apical side, you need to remember it's acellular cementum. Okay. Another thing, if I ask you, what group of principal fibers of the PDL is the first one to be degraded during an infection coming from gingivitis? With a question like that, I know that you know the group and you know which one is the first one. Cervical position is the alveolar crest group. Okay, so you have to be able to answer those questions. Okay. The oxytalan fibers, I like them. I do research in them. Regarding the function of the PDL, we start learning what they do. They may have a role protecting the blood vessels from compression. If you remember, collagen fibers and elastic fibers give the connective tissue the capacity to resist tension. We can pull the fibers, they can stretch, but there is a point in which they don't stretch anymore, and that's what gives the mechanical resistance to tension, right? The elastic fibers, because of elastin, add another capacity, which is the capacity to recoil. So we stretch them, we let them go, fast come back to the same state. The collagen fibers take a little longer for that. The oxytalan fibers are elastic fibers without elastin. So they don't stretch as much and they don't recoil. They are rigid. So it is believed that because they come from the cementum and then run parallel to the root, but mostly because they surround the blood vessels, it is believed that they gave a rigid, like, the scaffold, a rigid scaffold for the blood vessels. And this is very important when you go over orthodontic tooth movement, because when you push the tooth and the root, if these blood vessels are not protected, they're going to collapse and cause necrosis very fast. So that's the possible function. Okay, but so far that's all still supposition. Okay, regarding the glycosamine glycans, the ground substance, is very similar to any other connective tissue proper. 70% is water. That huge amount of water is necessary to allow the movement of cells in between the tissue. What cells do we need to move? Some fibroblasts, but mostly this is a tissue that is under constant attack by bacteria that normally live in the sulcular cavity. So those cells are all the cells of the immune system, and they require space to move. That space is created by water, and the water is maintained by the glycosamine glycans and proteoglycans. So that's the most important thing here. We talk about the fibroblast. The only important thing for you to remember regarding fibroblast, they are responsible for making the extracellular matrix and fibers, and they are able to produce and degrade fibers 8 times faster than the fibroblasts in the dermis. So these are cells highly specialized to maintain high turnover of collagen fibers. Why do we need to turn over our collagen fibers from the PDL? Because they are always under stress, and over time, there is going to be damage to these fibers. So we are constantly renewing them to keep the function of the PDL as best as possible. Okay. From a histological point of view, remember, close to the cementum and attached to the line of the cementum, these cells are probably cementoblasts. If you see a group of epithelial cells like this one up here, those are examples of epithelial rest of Malassez. Most of the other cells around here are isolated cells. All of these nuclei here are fibroblasts. And these structure here are blood vessels. Okay. On the side of the bone, you have to recognize bone here. Sorry, I'm using my finger here and you don't see it. So this is the bone, and the cuboidal cells attached to the bone, they can only be osteoblast. So I didn't put any image of PDL for you to identify anything. So regarding the physical functions, we talk about that. Resistant to mechanical forces, mechanical stress. And that is every single time that we eat or orthodontic tooth movement. Okay, so that's the easy way to. I keep the same slides that I gave you for oral biology, but now you already have Ortho 1, so I don't need to go deep into this. Just remember that the main function is to keep the tooth attached to the tooth. To do that properly, it needs to be able to resist to tension forces. In order to do that, the PDL has the best fibroblast in the body to keep those collagen fibers being fresh and new. Okay? That capacity, that plasticity is what allows you as dentists to do treatments in these teeth to correct malposition of the tooth, or to give space to add an implant, for example. If and there was an empty space and there was some migration, lateral migration of teeth, and now your patient says, I want an implant. So you need to make some space. So you're going to use orthodontic treatment to do that possible. All that is possible because the PDL is the kind of tissue it is. Okay. Regarding the capacity to absorb occlusal forces, there are two main theories. You just need to remember this part here. One theory is completely based on fibers. So the tensional theory says there is, oops, I lost it here, that the principal fibers are the main players in giving that capacity to resist occlusal forces. The other theory is the viscoelastic system theory, and is based on the movement of fluid. So one is collagen fibers, the other says is the capacity to move fluid from the tissue into the blood vessels and back that allow the resistance of mechanical forces. That's the only thing that you need to remember for this. This is all ortho. So for this, I didn't use this picture. I would have used this picture for ortho exam, but not for perio exam. So regarding nutritional and sensory functions, nutritional because being a connective tissue, and a very special ligament because in between the areas in which the collagen fibers are organized, like in a ligament, there are areas of loose connective tissue. And because of that, we have big blood vessels, lymphatic vessels, and that is what not only gives nutrition to the actual PDL, but also to the cementum and to the superficial bundle bone. Okay. Sensory, as I said before, we have the two more abundant are pain or nociceptors in the form of free nerve endings. Free nerve endings means axon without glial cells surrounding them. The second most abundant are the Ruffini-like receptors, and those are mechanoreceptors located in the apical third of the PDL. And I think I have here, yes. So trigeminal nerve, after it leaves the ganglia, it leaves three different branches. There's, let's say, more dorsal branch is the ophthalmic branch that goes towards the eye. Then is the maxillary branch, and finally the mandibular branch. And it's going to follow the similar passage of the blood vessels, and then it's going to go towards the PDL, and some are going to go all the way up, and those are particularly the nociceptors, the free end terminal ends. And then on the apical third, or these little black dots, corresponds to those Ruffini-like receptors. And these are mechanoreceptors. This is what gives the PDL the capacity to respond to mechanical stress. When we talk about chewing gum all the time or not masticating all the time. Okay, so critical thing here is remember trigeminal nerve, and that we have a branch that goes for the maxilla, a branch that goes from the mandible, and then it follows the blood vessels. And if we go for the blood vessels, remember that we have, in the case of the mandible, the inferior alveolar artery. In the case of the maxilla, is the superior alveolar artery. If we continue from the alveolar artery, branches are going to come. One branch goes directly inside the socket, and that branch is called the dental artery. From the dental artery, smaller branches are going to go into each PDL, into the PDL, and another branch is going to go into the pulp. Okay. From the dental artery, before getting into the socket, we have branches going into the actual bone. And then once they are in the bone, Some smaller branches can go back into the PDL through the foramina in the cortical bone that form the socket wall. And it's because of the foramina that allows the exit of those blood vessels that we call that the lamina cribosa, that cortical portion of bone in the alveolar bone proper. Okay? So I think mostly that's it. Yeah, I didn't ask any of this. Yeah, basically that's it. I have 25 questions for this exam. Okay. I think are like 8 questions are mucosa and gingiva. I think I have 7 questions for PDL, and the other are more or less the same for cementum and bone. Okay. But I have a few, very few histology ones, very, very few. And then what I can tell you for sure, you need to know the groups of fibers in the gingiva and the groups of fibers in the PDL. I have questions for that. Okay. And that's very important for the future. Regarding the final, for this exam, just to let you know, I'm teaching first years in that time because it's on Monday, I think. It's a Monday, right? So I'm going to start my class, and after 40 minutes, I'm going to give the D1s 20 minutes break, and I'm going to come to the exam. And so what I'm going to ask you is go over the questions and mark if you have any questions for histology or my subject, my content. So when I go in those 20 minutes that I have, you can directly ask me for the questions that you have regarding my portion of the exam. Okay? So that's just tell everybody else to try to do that. Mark my content questions and I will be there, but I only can stay for 20 minutes. Okay? Any other, and the exam is on the 26th, but if you have any other questions that you just remember, send me an email and I will try to answer the question via email, okay?